Now, coming on to our fifth section, that is the pain management of a trauma patients. As you know, the patient probably was having multiple fractures, associated multiple visceral injuries, maybe suffering from a lot of pain. So, pain management in pre-hospital areas and during hospital stay and during the transfer is very important. What are the different modalities for pain management? We'll be briefly discussing in this section. We'll be discussing intravenous and inhalational anesthesia, nerve blocks, and how to shift the patient to definitive care. So pain management could be through IV analgesia. That is usually now the most common mode is through patient control analgesia. That is the patient takes morphine. Most commonly it is the preferred technique by IV, and morphine is the patient most commonly used drug. Actually, it's diluted and titrated against the patient's response. And once the patient is feeling the pain at a certain dose is gone in the morphine, there's a machine which controls the dose regimen of the morphine, which can be injected into the patient. And if the patient feels pain, he or she can just press the button, and actually morphine goes through to the IV systems of the patient. So this is how the morphine is actually now used in form of IV analgesia or in the form of patient controlled analgesia. There's a wide variation in its effect, but most importantly, why it is important, because it actually provides a degree of mental detachment and euphoria. Therefore, it relieves patient of pain. But the problem is, this most important side effect is respiratory depression and sedation. Sedation is not that important, but respiratory depression which could be disastrous for the patient at times. So, respiratory depression, if it ensues post IV morphine use, then can be reversed. Although there are different other drugs which are available to reverse the effects of morphine. Preserving analgesia can also be done with the use of basically respiratory stimulant called as doxaparan. Our partial agonist buprenorphine can also be used, but although it must be avoided and not fully reversed by naloxone, because once if we give too much buprenorphine, once the respiratory depression sets in, it cannot be completely reversed. So it's usually those drugs that are used in which the side effects can be reversed by use of another drug. Other options are fentanyl and ketamine, although it's rarely utilized for the IV post-trauma patients, but in anesthetic agents, it's one of those anesthetic agents which have been utilized all over the world. Now coming to the inhalational anesthesia. This is a short-term analgesia which is employed by the anesthesia, and it actually includes nitrous oxide and oxygen in a 50-50 mix. And usually it gives patients a sort of a sedation as well as makes the patient pain-free as well, especially when aligning fractures and moving patients, because at that time the movement of the bone actually produces a very severe form of pain. Therefore, this is a very good mechanism in which, for example, reduction of the fractures under anesthesia can be done. Actually, nitrous oxide is used, which diffuses into the air-filled cavities, where what happens is actually as the cavities expand they expand volume with a factor of 4. That is, for example, it's the power of 4. If we are giving 4 points, then it actually the effect is such as 4:4. That means almost 64 times the normal value. So methoxyfluoride inhalers can be used in place of Intonox, although different inhalers are available and different mixtures are available, and then there is institution-based guidelines. Different institutions use different guidelines for inhalation anesthesia during fracture reduction. Then comes the nerve blocks. Although nerve blocks are not isolatedly used, but there can be a very good adjuncts to inhalation anesthesia, especially during the fracture reduction maneuvers. In some limb injuries, for example, risk of masking compartment syndrome as well, because patient may not be feeling that much pain, although there may be associated compartment syndrome as well. Femoral nerve blocks can be used for mid-shaft femur and anterior thigh and knee injuries. Why it's important? Because post-operative patient may be feeling far less pain as compared to normal spinal anesthesia. Now, there's a term called intra-hospital and intra-hospital transfers. As we discussed the organization, there may be centers which may not be taking in trauma patients. Then there are level 2 trauma patients which can take one systematic trauma patients as well, who can be managed over there and then can be referred to the primary care, then be referred to the tertiary care hospital Then there are level 1 trauma centers which can take all types of polytrauma patients. So if the patient is actually arrived at an area where it's not a level 1 trauma care center, then probably once the patient is stabilized, secondary service done, then that patient needs a transfer to the level 1 trauma care center. And if the patient has arrived in the level 1 trauma care center after stabilization, primary survey and secondary survey, then it needs definitive shift to a area where the definitive care can be done. So transfer is inevitable at some point, indicated when patient needs exceed, which for example results by the resources immediately available. Questions which need to be answered before transferring a patient is then when I need to transfer this patient, where I need to transfer this patient, and who should I contact when I'm transferring this patient, and what is the reason in which I need to transfer the patient, and by what mechanism, that is by ambulance, by air ambulance, or by intra-hospital transfer is needed, and with whom I need to transfer this patient, that is what is EMS team available or which can take care of the patient and transfer this patient either intra-hospitally or towards another hospital. So definitive care is important because it describes specialist care required to manage injuries identified during the initial assessment and subsequent investigation. So they address a particular problem for evacuation of intracerebral bleed. For example, patient had an extradural hematoma. Now, once the patient has been stabilized, diagnosed that this patient has an EDH, then the trauma center cannot evacuate the trauma. This needs surgical reference to the neurosurgery department, who are actually trained for evacuation of intracerebral bleed, and they will take care of the extradural hematoma. For example, critical care management is required. The patient is on ventilator, and although chest tube has been passed, fracture is splintered, the patient needs critical care, then probably has to be referred to the critical ICU department to provide systemic support as well. In this section, we'll briefly go on what are the modes by which we can give patient analgesia, and why analgesia is important, because usually during the movement or transfer of the patient, if there is associated fractures, moving limbs, fracture parts are actually highly painful. Therefore, analgesia has to be given so that the patient is at least comfortable when during the transfer, whether there is transfer towards the level 1 trauma care center, or once the patient is stabilized, all the primary and secondary survey has been done, then if the patient is being actually transferred to the definitive care facility, still patient needs to be pain-free. Thank you very much. Keep watching sqadia.com.